All right. Well, welcome, everyone. Hello, everyone. Bonjour à tous. Welcome to the second of 3 webinars Born Ontario is hosting this month to learn more about the readiness survey to collect and use social demographic and social determinants of health data. We will refer to these data as SD and SDH data or as health equity data. My name is Pascale Girouard-Frappier, and I'm the Regional Coordinator for Prenatal Screening Ontario, housed at Born Ontario, and I'm delighted to be your moderator today. I will also be joined by Alicia St. Hill, Executive Director at Born Ontario. Health equity at Born is everyone's business and infuses every sphere of our work. So I'd like to start by acknowledging the 17 members of Born's Internal Health Equity Advisory Group, whose contributions have made the dissemination of the SD and SDH survey and today's webinar possible. Note that the chat function is turned off. However, the Q&A feature is active. Please make sure you click on the Q&A at the top of your page. You may have to click on the 3 dots at the top right to find this feature and enter your questions here. As a start, we'd like to know who's in attendance here today with us, so feel free to write your name and what organization you're representing today in the Q&A. And with that, let's dive into today's session. I'd like to start by sharing a land acknowledgement. So acknowledging territory is only the beginning of cultivating meaningful and reciprocal relationships with First Nations, Inuit, and Métis peoples and communities. Nous rendons hommage à tous les peuples autochtones de la région et de toutes les nations à travers le Canada qui considèrent Ottawa comme leur foyer. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. J'aimerais débuter en reconnaissant que la terre sur laquelle nous nous rassemblons est le territoire traditionnel des peuples Haudenosaunee et Anishinaabe, le peuple original de l'île de la Tortue. Reflecting on this land acknowledgement, Born is aware of and seeks to adhere to principles of Indigenous data governance and supporting Indigenous sovereignty with access to information and health data. Safe self-identification and use of such data must first involve building relationships with Indigenous people, community, and organizations, and supporting their health information needs. Through this survey, we hope to learn more about the efforts of our data partners in supporting Indigenous wellness and data governance. Ontario Health continues their consultation around Indigenous identity data collection. Therefore, they do not yet propose specific wording for these questions and answers at this time. We recognize these data as a part of a whole person's identity, and we acknowledge that these are missing in the current guidance. And we are asking in this survey, how would you or do you approach collecting Indigenous identity information? So you may be wondering why the survey we shared with all of our data partner earlier this month asked many questions regarding the organization's current SD and SDH data practice and collection. We have invited you today to ensure we share the context behind this initiative and provide you with the following insights. Why are we launching into the collection and use of SD and SDH data? What insights are we hoping to gain from the dissemination of the survey? And also a few tips on how to fill the survey. How do we intend to use the results of the survey? And finally, we want to answer your questions regarding the survey and this initiative. Further, we're excited to be joined by care partner guests, Shâdé Chatrath from Breathe Midwife, as well as Dr. Crystal Clark from Women's College Hospital. And let me introduce you to Alicia St. Hill, Executive Director at Born Ontario.
Thank you so much, Pascale. Hello, everyone, and thank you for joining us today. I'm Alicia, Executive Director at Born, and it's a privilege to be here with such a dedicated group of professionals who's interested in advancing health equity. Born was established to collect, interpret, and share high-quality data that informs care, from system planning to individual care decision-making. As a prescribed registry working under HIPAA, we work across a large continuum of care with many partners like yourselves. This broad reach helps us reflect families' lived experiences and identify gaps and inequalities in care. Prenatal Screening Ontario is a key part of our program. Originally focused on screening for genetic conditions like Down syndrome, it is expanding. The labs that perform multiple marker screening, testing used by over 70% of pregnant individuals in Ontario, have provided us with rare racial sociodemographic data. And while imperfect, this data has helped us to apply a racial equity lens to care and outcomes analyses we perform. But its limitations highlight the need for more inclusive data that reflects Ontario's diverse population and its intersecting identities, including language spoken, newcomer status, race, housing and financial insecurity, disability, and gender. But today's conversation is about more than just SD and SDH data collection. We're here to talk about connection as well. The N in BORN stands for network, and that's exactly what we are, a collaborative of province-wide networks of programs, clinicians, researchers, policymakers, and data partners. Together, we've made meaningful impacts in care and evidence generation. And as we continue to use health equity to guide improvement, we'll ask new and sometimes uncomfortable questions and uncover disparities and build solutions to close gaps in care. Because the outcomes we seek must be attainable by everyone in Ontario. Equity isn't a side goal. It's central to our collective vision, best possible beginnings for lifelong health. And today's conversation and the presentations we're going to hear and the accompanying survey, these are steps that we're taking to help make sure that our data, our systems, and the way we measure care and outcomes really reflects this truth. We're aware that organizations are at different stages when it comes to collecting and using sociodemographic and social determinant of health data, and that's really great. Our own journey at BORN has been long and nonlinear too, and continues. We began in 2012 with the launch of the BIS, the BORN Information System, a new platform that brought together data from multiple pre-existing programs. We collected information from the start about primary language and education level, for example, but placed limited focus on the completeness and capture of this information. Early in our journey, we engaged with more than a dozen Indigenous health partners. From those conversations, we listened and heard how we could evolve a registry to better reflect the traditional models of care, support for self-identification of Indigenous ancestry, and uphold Indigenous data governance principles. These insights help shape our thinking about how data serves communities and not just systems. Internally, we've built and sustained a culture of reflection and psychological safety by supporting by the supports of our internal health equity advisory group, formed in 2020. This multidisciplinary team helps us to stay responsive to the diversity of Ontario's birthing population. We encourage our team to grow in their understanding of equity principles, Indigenous sovereignty, reconciliation, and data governance, how to apply an equity lens to our analyses, and to strengthen the policies that govern this work. In 2021, we were pleased to strengthen the advice that we received from people with lived experience and expertise outside of our program through the creation of our external health equity advisory group. In 2021 and 22, BORN researchers and partners published a study showing racial disparities in perinatal outcomes, even after controlling for other risk factors. These findings sparked new insights and hypotheses, and as we continue to examine outcomes across socioeconomic and sociodemographic lines, including recent work that we've done on postpartum mortality, we're increasingly aware of the limitations of existing data. But publishing alone isn't enough. We are committed to bringing people together, like we are today, and in many, many further examples, to understand why these differences exist and to measure the impact of the interventions we put in place. And we're actively building our internal capacity to do that type of engagement. Through recent work with Ontario's Pediatric Diabetes Education Program just this year, we've learned from local teams how to safely and meaningfully collect social determinants of health data from children and youth. This work was shaped by thoughtful engagement with care teams and families to ensure the process was respectful and secure. Early feedback from one center already using this data in its workflows shows how it's helping to tailor their care in meaningful ways, reinforcing that even the act of collecting and asking these questions and collecting this information and using it in care can lead to better experience and outcomes. To improve outcomes for all families, we need to understand the broader context of their lives, not just the biology and the administrative data, but the social, economic, and cultural factors that shape health and life in Ontario. This represents a culture shift. It challenges us to move beyond the traditional approaches and recognize that access to care isn't equally distributed and that there are numerous barriers to best outcomes. We must not ask when we do our analyses how many are receiving excellent care, but who's not and why. For clinicians, Sociodemographic information, especially when safely self-disclosed, helps to tailor care in an individual context to real and perceived risks and needs of patients. For example, if we ask patients to share their food insecurity concerns with us, clinicians and care teams are better positioned to help them navigate available perinatal nutrition supports and resources, allowing our care models to better anticipate and proactively address these issues that could affect pregnancy outcomes, such as low birth weight or high bleeding risk from anemia. Bleeding risk is the leading cause of perinatal mortality within the first 6 weeks after childbirth. From a programs perspective, both from local programs to provincial programs, we can use this type of data to allocate resources to tailor our programming based on the populations who come through our care settings and use our services. We know that hypertensive disorders in pregnancy are a leading cause of both maternal and infant mortality and morbidity, and the rates are rising. If we see higher rates of preterm birth from preeclampsia among certain racialized groups or specific neighborhoods experiencing higher levels of deprivation, those insights can drive our collaborations that tailor outreach, early prenatal education, and messaging about low-dose aspirin safety, screening, and other services in collaboration with the community. This kind of data-driven coordination helps to ensure that the care that we create reaches those who need it most and how they can best access it, while using our system resources for targeted approaches to improvement. In multiple marker aneuploidy or phylogenetic screening, race is used to adjust for biomarker differences observed between populations. Our PSO program is doing a deep dive to understand how these adjustments continue to affect the screening outcomes. But lab requisitions only tell us part of the story. Richer intersectional data must come from elsewhere to help us better understand the differences driving the use of race, as race may be a proxy for other underlying factors that affect screening performance more directly. Furthermore, as screening programs expand, we're looking at ways that we too can collect and use SD/SDH data to learn more about who may be missing out on accessing these services and to improve our program quality. Community organizations, for example, Indigenous health organizations or community-based parenting programs, all can and some already do use this type of data to ensure services are culturally relevant and support key health issues. As Ontario expanded its RSV protection program for infants last year, understanding who made up the nearly 25% of infants who remained unprotected from RSV after discharge from birth hospital and the social context around them and their family means that in future seasons we can better tailor our approaches in partnership with clinicians and community to be more responsive to family perspectives, values, and beliefs that may be impacting their participation. These kinds of approaches build trust and improve our engagement with care. We look forward to working in partnership with ICES as we use the RSV data we collected from last season to help uncover more sociodemographic information already collected about individuals, including newcomer status, to give us better insights about the equity of that program. Researchers, including those focused on clinical and social sciences, can also use these published insights to further explore disparities in care. Beyond the medical correlations, we can shed a light on some of the mechanisms or structural inequities or discrimination even that may be at play in perinatal mortality and morbidity. But above all, we collect and use this data to drive accountability. Without it, inequities remain invisible, silent, poorly understood, and unaddressed. With an equity lens, we can track progress, identify gaps, and hold ourselves accountable to individuals and the public, ensuring equity isn't just a goal, but a measurable outcome. The uses of our insights extend far beyond our health system. Many of you know that what is influencing health is more than what occurs within traditional healthcare settings. Where external factors play a role, like many of the real-world examples I shared before, it's a responsibility to raise these up as opportunities for improvement to government and other people in position to support better outcomes from life's very beginning. So we've launched this survey to understand how practices and organizations across Ontario are engaging with their patients and clients to collect and use this data, and whether it's being asked and collected in ways that align with the questions and options that Ontario Health's guidance on collecting and using sociodemographic and social determinants of health data published last summer. This will inform our work as we plan ahead, and we're very grateful for Ontario Health to making this provincial resource available and being leaders in this space. So we've invited you to join us in this learning opportunity. Whether you've already completed your survey or just learning about it, we're glad you're here. And we're glad that our partners are willing to share their journey with us. Your survey responses will help us take a pulse on current activity and readiness across the sectors to collect and use SD and SDH data. And the survey, to start, was shared with midwifery practice groups, birthing hospitals, and public health units. It's going to inform our next steps about data collection, governance, and use at Bourne and PSO. It's going to help us identify leaders and champions and early adopters who can support much of the peer learning and networking we need to make some important steps forward. It's going to help us also understand where support is needed and to encourage the adoption of activities that are leading practices for how we ask, collect, use, govern, and engage individuals and families, and what we learn and how we can better support them. We hope it'll also fuel partnerships. The aggregated survey results will be shared with all of you, our partners, but also the Equity, Inclusion, Diversity, and Anti-Racism group at Ontario Health, the Parental Council Maternal and Child Health as well, who are both focused on this work too. And lastly, they'll help us explore meaningful use and data exchange options for prenatal, postpartum, and primary care settings. Because some of our work that we have planned for the near future at Bourne, using our unique registry authority to directly impact care and outcomes with digital health solutions that reach the individual and family and their clinicians, with a goal to improving the safety, care engagement, and access to timely personalized care and insights and information. These same digital health tools can also be used potentially to support private and well-governed sociodemographic data collection directly from individuals that we can use both in patient care and in health system analyses. In addition to engaging with people with lived experience and pregnant individuals and the public about this, we've also asked some questions in the survey to better understand how you might envision using SD and SDH data that patients or clients wish to share with you, but that comes from external sources. Thank you for joining us today and for the time you've already taken to share your journey with us. I'll turn it back to Pascale, who's going to provide us with an overview of the survey.
Thank you, Alicia. If you have any questions for Alicia or on anything that we have been discussing, please feel free to share your questions in the Q&A sections as we go. So we wanted to give a little bit of an overview of the survey. The survey that we shared was developed through various community and partner engagement opportunities. And so last year, as Alicia pointed out, Ontario Health published their guidance document on SD and SDH data, which help us shape our survey. So after piloting the survey, we simplified the version based on the feedback that we received because it was a little too long. And so here's what here are the kinds of questions that you might expect to find in the survey. So section 1 to 5 are for all respondents, while sections 6 to 10 appear only for organization working towards or currently collecting SD and SDH data. The first questions ask whether your organization collects SD or SDH data, who collects it, when and how it's stored, and what barrier might be existing at your organization that's making this challenging, like limited resources or lack of leadership buy-in. A few extra sections to highlight. So section 5, data governance. We ask here whether receiving an SD and SDH data from other sources might be helpful and how your organization approaches governance. This helps us understand readiness to manage ethically use sensitive data, as we know strong data governance is essential to build trust with patient and communities. Collection content in section 6. In here, we're curious to know whether your organization uses the Ontario Health Guidance document. The use of this guidance may support consistency and standardization in our data collection effort. So even if you're unsure, you will have the opportunity to upload the questionnaire you're using at your organization directly in the survey, or you can email it directly to our equity email and our team can review the survey. In section 9, in community engagement, we want to learn about how community leadership is involved in your data journey and whether frameworks such as EGAP, Engagement, Governance, Access, and Protection, a framework published by the Black Health Equity Working Group, or OCAP, Ownership, Control, Access, and Possession, copyrighted by the First Nation Information Governance Center, were considered. This helps us support other sites in deepening community engagement. And finally, in section 10, we're interested to know how this data is used or intended to be used at your sites to drive meaningful change for equity-deserving groups. The call to action from communities has been loud and clear, and that's why we're thrilled to welcome today's guest speaker, who are not only passionate about the work that they're doing, but are making a real impact in their community. To start, please join me in welcoming Shâdé Chatrath. Shâdé is also known as the baby catcher. She's a registered midwife who works at West End Midwife in the GTA and surrounding areas for the last 15 years. She started her journey supporting people with their health and wellness goals. However, she loves to tell people that the seed God planted in her was to become a registered midwife. She recently helped to create a division of midwifery at William Osler Health Center and eventually was appointed the division head of midwifery, where she works endlessly with an amazing team of midwives to integrate midwifery at a hospital level. She also is the co-chair of the Black Excellence Group at Osler, where she focuses on supporting and celebrating Black excellence year-round. Her work and life experience led her on a recent journey to start a nonprofit registered charity called Black Reproductive Empowerment and Transparent Health Equity, or BREATHE Midwives. The goal of this is to decrease the disparity for Black birthing individuals, their infants, and family who face and improve their experience of birthing and birthing outcome through free access to care, services, programs, and resources. Shâdé, thank you very much for being here today. I believe we will support sharing Alicia. Welcome.
Thank you so much for the invitation and all the amazing work that you guys have done. And I'm really honored to be here. I'm just going to share my presentation. Are you able to see it?
Yes.
Okay, awesome. So as introduced, we are BREATHE Midwives, which stands for Black Reproductive Empowerment and Transparent Health Equity. So we use the word breathe because breathing is known to help improve health. There's been a lot of things in the media, if you guys remember, with George Floyd about he couldn't breathe. So we thought the name was really fitting. And so that's a little bit about us. So in terms of, before I kind of go into kind of all the social determinant of health, how we kind of use it, I just wanted to talk about our breath initiative. This really is the key foundation of how we serve the community, how we run our programs, how we advocate for people, and how we collect data. So there are 6 key elements that really focus on these things. And one of them is Black. So we're really putting Black individuals at the forefront. We're kind of listening to them, using their voices to kind of collect data and then make programs and services. The other one is resilience. So how people have to fight to be heard, to be advocated, but also to celebrate the strength that they have as well. Empowerment, we want everyone to feel empowered. So the data that we're collecting, we want to be able to use it and utilize it and use empowerment. Advocacy. So we're trying to take this information, the programs, and advocate for the people that come and seek our care. Trust is a big one. So whatever we're doing, whatever we're collecting, whatever we're asking, we want there to be trust. We want people to know. And healing. There's just a lot of generational scars, a lot of mistrust. And so we're kind of healing from all of those different things. So I just wanted to kind of give like a little bit of a synopsis into kind of like what we do. So our community is amazing. It's diverse, lots of energy. And so I just wanted to kind of share some of the data that we do collect. So we have a vast range of different individuals that kind of seek our care, and it spans from youth or young adults into seasoned adults, as I like to say. And the majority of the people are ranging between 18 to 44. We do hope by collecting this and trying to expand and understand our community that we'll be able to expand a little bit more beyond this age group. As we said, we are a Black focus, but that doesn't mean that we do not have allyships with other individuals. And we have found that people still come to us, still reach out to us. And so while majority of the individuals that we do support are Black, we do get other individuals. The tendency tends to be South Asian as well as Hispanic individuals that come to us. Majority of the individuals that do seek our care tend to be uninsured. And so it is no surprise, as a registered charity, one of our mandate is that we want it to be free access to care. We didn't want to have any barriers. And so it was really interesting to see the majority of the people that do come to us. A lot of these individuals are immigrants, refugees, asylum seekers. They need access to care. They have been turned away from other people because of the criteria they don't meet. Some of the other data that we do collect is address, to kind of figure out like where are people coming from. So we're located in Etobicoke, but we find that we're getting people from everywhere. It's very interesting how people talk and they find access when it's needed. We've had people contact us from Ottawa. We've had people who've driven from Barrie to come to us, and even have moved into a friend of a friend's house just to be able to be closer to have access to care. We collect data on gender. We also collect on disability, the types of caregivers that are referred to, how many people are actually getting accepted into care. So the way we work kind of on a drop-in, walk-in basis. There's no attachment. So what we do is we try to refer to other care providers for longer term. But if we can't get people in, they're more than welcome to come. So we're collecting the data, how many people we make referrals for, and they actually get accepted, and then mental health. So this little chart here just kind of shows most of the people that seek our care come from the GTA area. 100% at this point in time do identify as female. Most people get into OB care, and what we have found is based on the structure of how midwifery practices work. So they are allocated specific funding amount of people. So sometimes it's a little harder to get into care. So that was very, very interesting to find from the data. And we find that about 87% of the people are getting into care. As we know, there's a shortage of healthcare providers. So everyone isn't going to be able to get into care somewhere. And no surprise that a lot of people do experience depression. And so that has really shaped the type of programs that we offer for people. So data collection, when and how we collect it. And so there are three kind of key moments that we collect our data. So one is when people check in for prenatal, postpartum, and infant checkups. And so I just have a screenshot here of what that might look like. We have it also when people are registering for some of our programs. So we have a home visitor community program where we go either into the hospital or the home to see people and connect with them. We have like a mental health program. So we're collecting a lot of data to just make sure that we are able to support them in these programs. And then the last time where we're really collecting is to get feedback about the services and programs and what they would like to see from us. So there are various ways that we do collect and have collected the data. So we've used something called JotForm, for example. So it's kind of a survey questionnaire platform. We eventually upgraded to HIPAA to be compliant, and just because we were finding we were going to need more information that was personal, and we wanted to make sure that this information was safe. We also collect information using our EMR, because as we said, we do some care for our individuals. They're signing waivers, and so we have a cloud-based server. We use something called OceanMD. This is what collects kind of our intake to get the data that we then use to provide access to care. We've used Adobe Sign Form as well. Depending on the individual's knowledge language, we did find that sometimes it could be a little tricky for them to utilize. Initially, before we got cloud database, as a nonprofit, we're dependent on funding from the community. We used something called Sync, which was a cloud database secure system to be able to store some information. And we've also used something called Miato. So here I have some screenshots. I'll go slowly just so you can kind of see. These are some of the questions and the data that we're actually collecting. And so here we're asking in terms of ethnicity and race. So we try to be as detailed as possible without overwhelming, because we did find that the more information that we had, that it could be a little overwhelming for people, especially again, if English was not their first language. Here, for example, we do have questions about mental health. As you saw from the data, a lot of people do experience that, depression. Whether they call it depression or not is a whole different thing. But we did want to get into different questions that could lead to anxiety or depression. Some of the things that we did try to do, and this is Ocean MD, and one of the things that I do like about it, if you can kind of see here, this little sidebar, you see some things that are kind of highlighted in red. So depending on the response the individual has, you can set up the questions and the response to be certain colors to have flags. So for example, if someone identify as Black, African, or Caribbean, or Indigenous, it would be red. But if they were another racialized group, it would be maybe like an orange. So there's different ways that you can kind of highlight things that you want to make sure you identify so that you can provide better access and services to people. Here you can see we have a good array of different questions, like people are coming sometimes for postpartum, pregnancy loss, maybe it's about just sexual health and reproductive questions, mental health, feeding support, education. And so depending on what they answer, another bunch of questions would come, again, just to make sure that we are providing as much care based on the voices of the individuals who are seeking. Here's an example of the privacy, so the HIPAA compliance. So they will fill it out. When we get it, we don't see all the answers. And then what happens is that we do have to log in and then sign in with a password to be able to access the information, making sure, again, that it is very secure. In terms of program collection, we ask specific questions about the type of programs. We collect information about how many times they're actually utilizing our services too. So again, if someone was able to get into care, then they might have used our services 1 or 2 times. But if they weren't able to get into care anywhere, they might have used our service 3 to 5 times, for example. We also ask about culturally affirming care. How is that important for them to receive? So how did collecting SDH data help us? So it really helped us identify at-risk populations. So again, collecting this data helped us to recognize individuals and families who may need the extra support and making sure that they weren't falling through the cracks. It enabled target intervention. So like I said, we were able to collect more specific data, really design and change some of our programs, to make sure that they had the better outcomes. And then it helped us to inform policy and care. So it guided our clinical care, our policy decision, and it really helped us to advocate for healthier communities. So as some of you might already know from the Senate subcommittee, socioeconomic factors account for 50% of health outcomes. Healthcare accounts for about 25% of health outcomes. Genetics accounts for 15% health outcomes, and physical environment accounts for 10%. So these are really important factors for us to just remember that it's not just going to be one thing. There are different things, but socioeconomic was a really huge thing for us. So how are we taking action? I want to be mindful of time. So we're taking action. We're creating services and programs for Black individuals using a social justice and culturally affirming framework with health equity at the forefront. And so this really has led us to have access to care, so offering programs that are accessible and giving them education and bringing awareness to change the system when it comes to Black reproductive, sexual, birthing, and infant health. It helped us to really remove some barriers, so addressing and removing barriers that make access to healthcare difficult. So instead of just putting like a Band-Aid solution, right? So sometimes we'll create programs, but how are people getting there? How are people, accessing those programs, utilizing? Does it really work for them? And then it really allowed us to use the concept our community. So you take the concept, it takes a village to support, nurture, and build community to support older and future generations. midwives. And if I still have a little bit of time, I would love to still share stories. But in general, the stories, it just really helped us to improve outcomes, really integrating the social determinant of health data led to earlier interventions, healthier birth, and several families in our care. It really allowed us to collaborate with local organizations, provide essential resources, easing prenatal postpartum transitions for new families. And it really helped us for voices from the fields. Families and care providers reported feeling more empowered and supported when we used the social determinant of health as part of their care journey. And one story that someone did give us permission to share. So it's only been a year since we started our life here. Having a baby was never in our plans so soon. And without a health card, the thought of pregnancy care felt overwhelming. Each day we worried about how we would manage the cost and find proper care. Then, like a blessing, we found Breathe Midwives. They welcomed us with open hearts, listened to our fears, and guided us with compassion. They helped us find midwives who are now taking care of my wife without asking for anything in return. In that moment, we realized it's not just medical care they gave us, but love, hope, and a sense of family when we needed it the most. To the trust and the midwives who stood by us, we are forever thankful for your kindness. So I think it was just a good way to just kind of summarize some of the ways that, again, social determinants of health really allowed us to really give proper care for people, specifically for what they needed. So some of the challenges that we do face or have come across is privacy concerns. So we've been really working hard to make sure that the data that we do collect is private. Some people are really hesitant. Sometimes they don't want to take our care just yet until they do research, until they really know. Some are, afraid of immigration. We found that there's different inconsistent methods. So it depends on the tools that we use. Some would do it one way, some were a little bit easier to navigate, as I mentioned earlier. Lack of standardization with some of the tools. Again, some were a little bit different depending on the community that you were working with, the organization. And then there's limited routine collection. So not everyone is collecting data. So we were collecting some, other people weren't. And so, that can be a little bit of a barrier. How we can make improvements. Standardized screening. So just make sure that the tools are standardized across the board. Staff training is one of the things that we found. Community collaboration, and then personalized care plans as well. Next steps for us, diving deeper. So we want to dive deeper into access to care, like how far are people traveling, how long it takes them, what is the mode of transportation. We want to explore culture a little bit. It's very complex. You can have two individuals who identify as African, but that doesn't mean anything. We wanted to look a little bit more at social safety nets. So what policies, programs are being utilized by individuals to prevent negative outcomes. We wanted to look at self-care and wellness a little bit more. We found that you can't really always use the word mental health. That's a very big stigma. And so we actually had to change the name of some of our programs because mental health, you don't have mental health issues. You don't have depression in a lot of the Black communities, for example. We want to figure out trust in the system. So one thing that we couldn't figure out how to collect was a person who left one caregiver to come to us or to go to another caregiver because they didn't feel safe. They didn't feel like they trusted that. So there was just no way to kind of capture that or report that. And then collaboration. So how the different collaborations between various programs and professional organizations play a role. So moving forward, the last slide, there really is no point in collecting data if we're not going to listen. Data is only valuable if it informs decision, action, and insight. Collecting data without analyzing it, understanding it, or acting on it renders the efforts wasteful and ineffective. There's no point in collecting data if we're not going to use it. Don't just talk the talk, but let's walk the walk. Funding partnerships and collaborations are also important to make this work happen. Thank you.
Thank you so much, Shâdé, for this really incredible presentation. I think it's really striking how you're really able to use your data and really put it into action to support the community you're serving. Thank you so much. We see some questions coming into the chat. We'll make sure to return to those after our next presenter. Let me join me in welcoming Dr. Crystal Clark. Dr. Clark is an internationally recognized psychiatrist in women's mental health. She is the Canada Research Chair in Reproductive Mental Health, Associate Professor in the Department of Psychiatry at the University of Toronto, and Associate Head of Research at Women's College Hospital. Dr. Clark specializes in mood and anxiety disorders, specifically across the reproductive lifespan from menstruation to peri and postmenopause. Her research aims to address gaps in psychiatric health care through development of identification and prevention strategies for marginalized populations in psychiatry, including visible minorities and those with severe mental illness. To this aim, her work focuses on birthing people who are of African descent, as well as perinatal people with bipolar disorder. Dr. Clark is the past president of Marseille of North America, an organization dedicated to advancing perinatal mental health care, and she serves on the board of directors of Marseille International. She has been a contributor to large initiatives in the US and Canada to improve perinatal mental health in North America. Her research has been funded to the National Institutes by the National Institutes of Health. Dr. Clark, thank you very much for sharing the work you're doing with us today and for being here today to talk more about it.
Hi, thanks for having me today, and thanks for that introduction. I will also start by sharing my slides and also giving everyone a little bit of background about me, so you know where I'm coming from with this presentation. But let me share first. Okay.
And we can see your slide.
Yes,
Thank you.
Right, perfect. All right, so a little bit about me. I still consider myself new to Canada, meaning that I joined, the community back in only 2.5 years ago at this point. I'm coming from the US, where I was born and raised mostly in Chicago, but as I've heard from many Canadians, those of us who are American tend to move around a lot. So I've lived all over the US, and I'm now in Canada. And one of the reasons I came to Canada was to lead research and clinical programming around Black maternal mental health. And I always share with people that I had no way of knowing, or even you don't know what you don't know until you know. So I had no way of knowing that there was no race-based data collection when I was asked to continue this effort that Women's College Hospital thankfully finds and has found very important to their vision. But when I got here, I was pretty shocked that, well, how are we going to help with Black maternal mental health if we're not capturing the data to really highlight where the needs are, to support the grants, to support the policies, and coming from the US, where these issues are definitely major. I'm very aware of what data can do and what lack of data can do as well. So I'll start. What this presentation is going to be about is really that journey in my time here in Canada thus far, and my efforts to characterize and capture and understand what is the Black experience as it relates to maternal mental health in Canada and Toronto and the Ontario province in particular. So what I see as the issue, to some degree, and I'm sure people can add others, is that in Canada specifically, we have limited race-based data collection that has made it difficult to characterize our Black maternal mental health experience, the outcomes, the needs, what's the best treatment, what's the best intervention, what's the best prevention. And to start to address that, as an outsider, I came into the community meeting with the community. Well, what does the community feel? Because I didn't want to place my perspective on anyone. And I was being told by many that, oh, this isn't an issue. So I said, well, let me go to the community and see if it's an issue. So in conversations with 6 community organizations, and that's really a small group or a small smattering. I would say the six biggest organizations I met with, because I've met with many more organizations across my time here, but through six major organizations that serve the Black community, there was a resounding theme that there were concerns for disparities and requests for data to support resources. So I went anywhere from the midwifery groups to the Black doulas to some of the community health centers, discussing this and trying to better understand perspectives and if there was a need for further understanding and characterization and care. And as I continue to speak with people, the diverse community of patients, just everyone was saying we need more data, we need more help. So I determined that more research was needed to support any disparities, as has already been stated by Shâdé, establish preventative care and ensure optimal outcomes. All right, so just to highlight some of the background, why I even find this important, is that mental illness impacts as many as 20% of pregnant and postpartum people. So that's 1 in 5. You think, 5 people that have had a child, they likely have suffered with postpartum anxiety, depression, or some other psychiatric illness. We know that Black birthing people may be at higher risk of experiencing new or recurrent episodes of mental illness during pregnancy and postpartum, and are at risk for undertreatment of mental illnesses when they occur. Why? Because we are often not screened for mental illness. It goes unidentified. When there is treatment, there's not a lot of education or awareness around the options. There are cultural differences in approach to mental health and so on and so forth. So this really impacts our ability to get well, and this can leave us suffering in silence. So I set out to just even understand how we are managing this issue at Women's College Hospital, kind of just a local assessment, but also requesting their support to further look into the community, really building it on their mission and commitment to equity, stating that dismantling anti-Black racism and measuring what matters is what they're concerned about. And I felt like this project, as I'll share with you, looking at Black maternal mental health and identifying Black patients who are pregnant and postpartum, was very much on par with the mission of the hospital and the mission of my work. So just highlighting, there are several prongs to the work I set out to do, and set out to do quality improvement in our psychiatry program at Women's College Hospital. I'll share some of my journey with that. I then set out to also get a provincial grant looking at data across Ontario for Black maternal mental health and obstetrical outcomes. And I've also set out to do things in the hospital to really capture our understanding of the Black experience, whether they're going through OB or psychiatry, and ideally where that overlaps. So to look at data locally, I started asking for demographic collection in our psychiatry department simply. Just can we understand who we're seeing, whether that's, whether it's race, ethnicity, sexuality. Those are some of the main gender, some of the main categories, and then, we can build that out even further. And I will tell you, I got a lot of pushback. People weren't comfortable asking about race. They weren't comfortable. They were comfortable asking pronouns, but not about sexuality. Which as a psychiatrist, I will tell you guys was very surprising to me, because I do believe that we are all trained very similarly, no matter where you come from. And part of our understanding and part of our assessment of the person in front of us is to understand the whole person and all the identities that they bring to that space. And at least that's how I was trained and how I've always practiced it. So we ask a lot of intrusive questions, trust me, about lots of other things. So race seems like a very low-hanging fruit, and as well as ethnicity, as well as sexuality. But again, being in a new land, I was, sensitive to the question, and have encouraged and tried to teach my colleagues how they might approach asking the question. The other thing we have set out to do is to just do interviews with the patients who are receiving care who identify as Black to better understand their experience. So just briefly, at just over a 3-month span, when I started this project back in 2023, we got some data from patients, and not many of them, first of all, we couldn't get all the data. So out of 348 patients, we could only really understand what was the demographic collection of 92 or 183 of them, and then 14 of those of 92 patients. So they're like, we kept breaking down in groups. So let me just go back again. So out of a total of 348 patients that presented over a 3-month period, we could only get data from 92 of the new consultations in terms of demographics. And of that 92, only 14 of them identified as Black. And my group was pretty pleased with this data. I was not, because I'm like, well, that doesn't tell us the entire group or enough about who we're serving and whether we're doing a good job or what's going on. But of this very small group, we understood that most of them were employed, Canadian citizens, and pregnant, and that about 43% of them had completed high school and completed college. So we got a little bit further into that social demographic collection. We got a little sense of where they lived in Ontario.
Dr. Clark, I don't mean to, just for the interruption. We did lose your video in terms of you're frozen on screen, but your audio is working very well. So please feel free to continue. We don't want you to stop and change anything, but I want you to be aware of that.
Are you seeing the slides?
So they're not advancing. They're frozen.
They're not advancing. Oh, okay. That is weird. All right. Well, you think I should really quickly stop sharing and reshare, or just want me to keep going?
You can give it a try to just quickly stop share and reshare, but didn't want to interrupt you too much. Crystal, are you still there? Hopefully she'll rejoin in a moment. Thank you for your patience.
Okay, it seems like I lost you guys.
Oh, you're back. We can hear you.
Back. Okay. All right. Well, we'll try really quickly one more time. Okay. For this, can you guys see it?
Yes, we
we
can.
can see your
Okay.
yes, because we care slide.
Yes, perfect. Okay. All right. So for the sake of time, I'm going to just speed through this a little bit, but the hospital implemented a sociodemographic questionnaire called We Ask Because We Care around the same time I was getting into this work in my department. And there's been an ongoing kind of push to maybe use this data instead of the automating the collection of the department data, which I'm very close to getting done. We are crossing my fingers by the end of this year that will be in place. But We Ask Because We Care data, the challenge has been around governance and how do we use the data, who gets to use the data, who gets to see the data, and many of us can't access the data. And they gave me a report, and basically 42% of patients even respond to the data. So again, you can't really generalize or fully understand what's happening with the population when you're only getting a percentage of what's going on. With all of that going on in the background, I decided to pursue research provincially looking at the characterization of reproductive mental health among Black birthing Canadians, what I call the Black Carrican study. And that was funded by CIHR in September of 2024. And through this, we were able to look at Black pregnant individuals, approximately 70,000 identified using the ancestry variable and the born information system. So thank you guys for that. And we're connecting that with ICES data. We're also looking, where possible, at Asian, Caucasian, First Nation, other and unknown populations. And we've already got some great preliminary data coming from looking at outcomes coming from this data set, and hoping to publish that early in 2026. But first, we'll be meeting with the community to discuss the findings and see where we might go next, but also how the community is feeling about what we're finding thus far. Our data variables include psychiatric diagnoses, obstetrical outcomes, markers of severe mental illness, such as emergency care visits for psychiatric purposes, hospitalizations for psychiatric purposes, and suicides. So I keep asking, what does the future of Black maternal mental health look like? I welcome any questions at this point. I'm hoping that it's looking bright because we will have more data to understand and support and intervene and prevent. So with that said, I will stop sharing.
Thank you very much, Dr. Clark, for this very inspiring, we wish, presentation. We will take questions now. So if you have some questions for Dr. Clark, please share them in the Q&A section. For now, we have some questions for Shâdé. One of the participants had to leave, but it might be helpful to share the question for other attendees. So the first question was, how do you use this platform with different languages? At the organization, they use the Ocean platform for some data collection and know that it's not a platform that can be translated through the web browser. So that was the first question. I'm not sure if Shâdé is still, oh, there she is. I don't know if you have any tips for that. Yeah.
Yeah, so that's some of the barriers. JotForm does allow you to translate. You actually have to manually go in and translate all the questions, but then there's like a drop down where they can actually select the language depending on what you can enter. However, that platform we found when we were doing kind of the bigger, longer questions, it was a little bit harder because it goes to an email and then you have to take it from the email and then upload it into the chart. So we were finding a little bit more difficult for individuals, whereas the Oceans, it integrates into our EMR, creates the individual, and then was saving time because usually when people are coming, like I said, they are coming to us because they haven't found access to care. They usually need a lot of everything because we're starting kind of from the beginning. They usually don't come very early in their care. So these were just things that we were just trying to figure out how we can spend more time for people, make it a little bit easier, but those are things that we're looking into.
All right, thank you very much. One more question for Shâdé as well. We are asking, at what point during the care are you collecting your data? For example, if mid-care is the response, Is in mid-care the response higher rate because the relationship between midwife and client has been established already? Do clients ask questions on their own data or how their data will be used? And do you think depression is higher among Black midwifery clients?
So the data is for when they come in or if they reach out looking for help and resources. So sometimes we'll get people that will send in a contact us, I need help, I'm pregnant, I don't know what to do. And so once they kind of come into our office, or if we have to do virtually because they're too far to reach to us, but we want to start the process, it would be similar to an intake process. And so a lot of questions are there. Whether they answer truthfully will depend on how much they trust the system. And so we do find that if someone does have to come back to us a few times, then things do, as usual, they'll kind of share a little bit more because now they know you, they trust you, they know that you're kind of got their back, they're in their corner. Sometimes people will just tell you everything because at that point they have nothing to lose, and they just want access to care. They want someone to just kind of hear them out. So it just kind of depends. And then more questions will come up if we need things to be clarified. We do let people know, we have like a waiver. We let people know that we are collecting the information. The information might be shared with other people in our circle of care. We might need it to do referrals. So we do make that understood. We also go through the paperwork too as well. So we don't just say, just sign this, but we take the time to say, here's this paper and document that you'll need to sign. This is why you need to sign it. These are the people who will have access to this information, and this is the rationale. So we do try to make sure that we are very transparent, as the T in our name, transparent. That's really important for us.
Thank you, Shâdé. And one more question, I think directed at both presenters. Attitudinal resistance is a huge barrier in SDD collection in Canada. What sort of talking points have you found effective in garnering buy-in from your peers?
I will jump in and just say that I have learned to often not use race, although I love to hear Shâdé's take on it, but I talk more about equity deserving and how do we build equity. I feel like it makes people feel more comfortable. Same concept as it relates to my work. And I share some of the positive things that I've found in doing this work, because I think there's a lot of negative connotations around looking at disparities, meaning that we're placing blame on someone in particular. And yes, there are some issues in the systems that we uphold, but no one's saying, well, it's your fault, this patient isn't getting the care they need. So I try to disarm people in that regard and letting them know that this is more of a joint effort and not a blaming situation, and we're trying to figure out just how we align together for the same cause.
Yeah, and I would say it's very similar to what Dr. Clark said. I do find it interesting. We've actually had someone who was upset and actually said we were discriminating and being racist because we were trying to serve the Black community, which I found very interesting. But also then it speaks to why we're doing the work, because people just don't have that understanding. And so it isn't about isolating or trying to prioritize one individual or group over the other, but really to understand that there are disparities, there are inequitabilities amongst different groups, and trying to understand why and how we can try to change that so that we can make access to care equitable for everyone. And so we do the work because it comes from somewhere. I've had experiences, the midwives that volunteer their time at Breathe also have had their experiences and stories. And so we know what happens, and we just want to make a difference.
Yeah, and I would also add that people have challenged me since I've been here about not looking at other populations. In fact, very directly about not looking at the Asian population. And my response to that has been, I want to look at every population, not just racial. You know, I've mentioned the LGBTQ community as well, but I also think it's very important to have people who reflect that community when you're doing that research. And I don't, you know, since I identify as Black myself, I feel comfortable in pursuing this research, but I would only partner with someone from other communities before I would ever go into another community trying to do research, whether that's Asian or Indigenous or any group that I don't identify with personally. So that also helps them understand my approach. So.
Certainly. Thank you very much. We have time for a few more questions if there's any questions in the audience. If not, and if more questions just come a little bit later, we wanted to thank you, merci, Miigwech, for dedicating this time to learn more about the Born's SD and SDH survey. It's been a pleasure hosting you, and we hope that this webinar has provided you with the appropriate context and information required to fill the survey. Please, prior to logging off, could you please ask just a few minutes to fill a few short evaluation questions about the webinar. It will help us improve our webinars moving forward. And you have here the Equity at Born Ontario email on the slide. Feel free to reach out to us if you have any questions or comments following this webinar. We're wishing everyone a wonderful rest of your day, and we hope to continue to collaborate with you, our data partners. Have a good day, everyone.
Thank you very much.
All right, thank you. Bye.